Good evening. Welcome to Rayos125, the online academic sharing platform organized by ISRT Kerala chapter to commemorate the 125th anniversary of the discovery of X-rays. I am Suraj Sugunan from Government Medical College, Trivandrum. The topic I would like to share with you is the basic approach to CT brain, especially designed for the beginners in CT brain imaging. Before beginning the session, let us pay our respects to the great human being and the greatest experimental scientist W.C. Röntgen, the father of radiology. Shown here is a rare picture of Röntgen in his official capacity as rector at Julius Maximilian University of Würzburg during the period 1893-1894. Here you can see the Nobel Prize certificate of W.C. Röntgen for his remarkable discovery of X-rays. He was the first ever Nobel laureate in physics. Now let us start our small journey through the CT brain. The fundamental concept of CT is that the internal structure of an object can be reconstructed from multiple projections of that object. The transmitted or attenuated X-ray beam having the information of the specific organ or object is detected by sensitive detectors. CT is a transmission type imaging modality. The basis of image formation, both in X-ray and CT imaging, are based on this fundamental equation I is equal to I0 e raised to minus mu x. The equation relates the intensity of X-ray beam before and after passing through the object with that of the thickness and linear attenuation coefficient of that particular material. This is another important factor while we are dealing with CT brain or CT is concerned. Wherever CT is concerned, CT number is very important. CT number is a dimensionless unit. The CT numbers are calculated from a linear attenuation coefficient values for each individual tissue or cell. Each elemental region of the CT image is expressed in Hounsfield units corresponding to the X-ray attenuation. It is calculated from reconstructed pixel attenuation coefficient. CT number is equal to 1000 into mu t minus mu w, where mu t is the linear attenuation coefficient for tissue in pixel and mu w is the linear attenuation coefficient of water. Hounsfield scale is a quantitative scale for describing the radio frequency where air has value of minus 1000, bone has plus 1000, and water has 0. Here you can see the CT number ranges of different tissues. So in the case of brain, we have the bone, white matter, muscle, gray matter, hemorrhage, CSF, fat, and air. So the mostly occurring tissues. Bone have a near plus 1000, and white matter is 20 to 30. Muscle comes around plus 20 to 40. Gray matter comes around 30 to 40. Hemorrhage, fresh bleed is around 65 to 95. It's very important to remember the range of hemorrhage densities and CS of water. CSF or water is around 0. Fat, that range is shown here is minus 30 to 70. Air, something around minus thousands. So whether in CT or in general radiography, positioning of the patient and part are very crucial for obtaining an acceptable image of diagnostic quality. While performing a CT head, always try to position the patient maintaining the symmetry on either side carefully by positioning the laser localizer. The laser beam has to pass through exactly the same points on either side of the head. So positioning in a symmetric way, position the patient head in a symmetric way as far as possible. If some cerebrovascular accident or some traumatic patients, you may not be able to position the patient exactly symmetrical as possible. But meantime, you try your maximum to position the head in a symmetrical way. While performing a city head, the technologist should know the area to be covered. Since our eye lenses are vulnerable to radiation, a scan angle of 15 to 20 to the candlemeter line is preferred. But nowadays, the volumetric nature of the image acquisition and very less overall radiation dose, people are not using this type of angulation anymore. The area to be covered is very important. While you are performing a CT brain, the area to be covered is very important. Usually, the area fixed it is from C1 lamina to vertex, including in traumatic brain injury. In traumatic brain injury, if the situation needs to cover from down, you can pull the box lower down, still bit lower down than the C1 lamina or C3 or C4 or up to the end of the mandible. You can start the scan. So you can pull down the lower limit to a little bit down for traumatic cases. For routine head also, it is better to include some maxillary sinuses. Maxillary sinuses are very important because often people complains about headache and the reason may be the sinusitis. So this is one of the very important slides for a CT brain imaging. This slide has very fundamental thing for a trainee technologist or for the beginner. As you all know, the brain has got gray matter and white matter. You are all familiar with the term gray matter and white matter. Gray matter is made up of cell body and white matter is made up of the axons which are myelinated or myelin covered. Since the gray matter is denser than white matter, it appears relatively hyperdense. That means whitish than the white matter in the CT image. So gray matter, you can see the outer coating here, the gray matter, and the gray matter is little bit denser than white matter. That means the denser objects of the denser gray matter will attenuate more X-rays and hence it appears a little bit whitish than the white matter. White matter is less dense than gray matter. So white matter is darkish in CT. So you can see the gray white matter differentiation. Since the gray matter is denser than white matter, it appears relatively hyperdense, means whitish than the white matter in CT image. In turn, the white matter with comparatively less density appear dark or hypodense in relation with the gray matter. Simply, gray is white and white is dark in the CT image. As a technologist, you should learn to differentiate or appreciate the differentiation between gray matter and white matter in a CT brain image. It is very much important. At least you should know where this gray matter is located, how it is appearing, and where are the white matter tracks and how it is appearing in the CT, and train your eyes to differentiate gray and white matter differentiation to differentiate it between gray matter and white matter. The next thing you have to be familiar with that of a brain is the spaces of a brain having the CSF filled spaces of brain that is called ventricles, the two lateral ventricles, third ventricles and fourth ventricle and their communication pathways. You should know how these are working and the ventricles and their communication pathways. Next is another important thing for a CT brain, that is windowing. Windowing is very crucial in brain imaging, even though it seems easy, quite easy at times, but it is very difficult, a very decisive factor for a variety of cases. A variety of cases, it is very decisive. Windowing has basically two parts, window width and window level or center. So there are two parts, window width and window level. Window width is simply selecting the desired pixels from the image. So we are selecting a very short number of pixels. We get a quires window. When you select a wide range of window, you will get a smooth window like that of a bone. You can select the range of tissues to be displayed. You can select bone window, you can select soft tissue window, you can select and any other window in question or window in requirements. And window level is the gray or white end of the gray scale. You can see gray scale on the white end and gray end. And window level is the selection of that background towards the white end or gray end. Here is an example to show you the importance of setting adequate window width and level. The images are same on the right and left side, but with different window end. The image on the right side is little rough or fast, or it is compared to left. Left is something smoother. Left and it seems normal. So on the left side, you can see a smooth image corresponding to the right side. Right side it seems square. So in the right side you cannot appreciate anything abnormal. But once you change the window, and that particular window is called a subdural window that we will discuss later. Subdural window, you can see, you can appreciate a thin film of blood along the cortical margin, revealing a subdural hemorrhage. So this hemorrhage is blinded in the right side window setting, and that the same section or same slice is having that piece of information is quite evident in the adequate window setting. So this is window setting is very important, very crucial factor in CT brain image. Another important window setting is to amplify the gray and white matter differentiation to the maximum is called a stroke window or a 40-40 window. In this image, you can very well appreciate the gray and white matter differentiation, which is very crucial to predict an evolving infarct. Suppose a young technologist is in the console, then a group of neurophysicians may accompany a stroke patient, and if the doctor suddenly asks the technologist, put the images in stroke window. Then you can exactly do the necessary changes in the windows and once you know what is stroke window. Stroke window is a narrow window that is to make the images squares, make the gray-white matter differentiation. Then the neuro people can easily pick up the evolving the differentiation between gray matter and white matter. They can predict something is happening to the patients. So these points are very important and crucial for a budding technologist. Here we can see a normal brain window and a bone window. Bone window is very important for traumatic brain injury cases. So measurements are very important. Some measurements are crucial in brain imaging. A technologist should know how to measure the reference levels for a particular importance. And that is here it is we can calculate or we can draw how to make a midline shift. The normal brain has two equal halves on either side. When one side pushes the other due to some or more reasons, like that of traumatic brain injury or any underlying pathology, the center will be shifted to the other side. Here you should know how to take the midline shift, the extent of shift towards on either side. Here it is to the right side. Right side means on the right side image. Actually, it is to the left side. In image wise, it is towards the left side. Okay, and here from the how it is measured is from the fox around the midline. From the center of the image in the midline, you draw a line downwards. That is the first line. One from the midline at the level of the fox, then one horizontal. You have to draw a horizontal line to the septum pellucidum, that is on the midline of the lateral ventricles at the septum pellucidum. Anything more than 5 millimeter is clinically significant. So this is how you should measure the midline shift. It's another slice of it is seems very important. Technologists are supposed to be familiar with the calcified areas of brain. sometimes routinely appearing. So these calcified areas are routinely seen in a normal brain. Here you can see the characterizing or the choroid plus. You can see the choroid plus calcification here. On either side is the choroid plus calcification. On the midline there is a pineal body calcification. And on the basal ganglia region, you can see the globus pallidus calcification. So calcification is common, and don't be get upset or misinterpret with the bleed or something like that. So be familiar with the calcification sites in normally appearing in brain. Like the calcification, these are some occasions while you are dealing with some traumatic cases or some real emergency pathology cases, you can have some, you can see some air bubbles on brain. These are also quite often during traumatic, severe trauma to brain. Trauma to under brain or underlying pathology, never get upset to seeing such matters. Here you can see something put inside into the lateral ventricles. It is a ventriculoperitoneal shunt to drain off the CSF in the hydrocephalus condition. Familiarize yourselves with such images. Here we can have two images. One with not that the same, it is the same window settings, but you can appreciate atrophy and normal. You should know how to uh, appreciate atrophy and a normal brain tissue. Here we can see the punched out lesions suggestive of multiple myeloma. So thinning of bone and punched out lesions are very characteristic of the multiple myeloma. Notice that bone erosions and density differences on the skull bones. Don't mistake it for artifact or something simple like that. So here you can see the lesions, a punched out lesion. It is very typical in multiple myeloma. So these are some basic images when you came across while you are doing the CT. Now we are slowly entering into the real business. Intracranial hemorrhages, the most important thing in a CT brain examination. Intracranial hemorrhages are two types: extraaxial hemorrhage and intraaxial. Extraaxial bleeds are seen outside the brain but inside the skull. Intraaxial blades are blades seen within the brain parenchyma or ventricular system. In a broader sense, intraventricular hemorrhages can be called as intraparenchymal blade. So once again, I repeat, intracranial hemorrhage is of two types, intraaxial and extraaxial. Extraaxial means the blood or the bleed is inside the skull, but it is outside the brain matter or brain parenchyma. And intraaxial means it is well inside the brain tissue. That is the two types of bleeds, intracranial hemorrhages. Before going into extraaxial or intraaxial bleed, technologists must have a clear idea about the various layers that offer protection to brain. The outermost thing in is the scalp. You can see the scalp, and below that is the skull. Then the periosteal dura mater. After that is the meningeal dura mater, or you can together call it as a dura mater. Then arachnoid matter, subarachnoid matter, pia mater, and the cerebral cortex. Coming into the extra-axial blade. Extra-axial blade are three types: rapidural, subdural, subarachnoid hemorrhage. Extra-axial blades are epidural hematoma, subdural hematoma, and subarachnoid hematoma. Then we will go one by one. So what is epidural hematoma and how it is appearing? So this is the epidural hematoma picture. It is always called extradural hematoma. It occurs between the skull and the dura mater. The main cause is trauma to head, otherwise called extradural. So this bleed is otherwise called extradural. The appearance is that of a biconvex lens. You can see a lens-like blade on the slice. So mostly associated with the fracture. So an underlying fracture may be seen along with EDH. The bleeding source is from always, not always, but more than an 80% of cases is from rupture of the middle meningeal arteries due to trauma or fall. So bleeding source is from middle meningeal artery. The type of bleed is arterial in 90% of cases. The most important feature of EDH is it won't cross sutures. It won't cross sutures. It has why that is why it is have a definite lens shape. It won't cross the skull sutures because dura is tightly attached to the skull. The dura mater is tightly attached to the skull. Since EDH, extradural hematomas, don't cross sutures normally. It's all about EDH. The subdural hematoma is a collection of blood below the inner layer of the dura, but external to the arachnoid membrane. It is the most common type of traumatic brain injury. The source of bleeding is from the bridging veins that cross the subdural space. SDH can be expand along the inside of the skull, creating a concave or a crescent, half moon, or a crescent. This is called a crescent shape, and they stop only at dural reflections, like tentorium cerebelli on falx cerebri. So it's a collection of blood below the inner layer of dura mater, external to the arachnoid membrane. It is the most common type of traumatic brain injury. The source of bleeding is from the bridging veins that cross the subdural space. The appearance is a crescent shape in the CT image. Then we will move on to subarachnoid hemorrhage. Subarachnoid hemorrhage, bleeding in the subarachnoid space, the space between arachnoid matter and the pia matter surrounding the brain. Ruptured aneurysms are mostly the culprits. Traumatic brain injury may also produce as a subarachnoid hemorrhage, rarely. SAH appears as hyperdense areas in the CSO-filled arachnoid spaces around brain. Often the cisterns and sulci appear hyperdense in acute hemorrhage. Here you can see the aneurysm, the saccular aneurysm is there. Aneurysm means dilatation of blood vessel. Once it's ruptured, the SAH can happen. Here is the intraaxial bleed. Intraaxial or intraparenchymal hemorrhage is the accumulation of blood within the parenchyma of the brain. Location and volume is very important. Here you can see the ventricles also filled with blood. That is intraventricular bleed. You can either call these intraparenchymal in two different ways, intraventricular plus intraparenchymal. But as a generic term, we can call it as intraparenchymal since it is seen the ventricular bleed also seen within the brain tissue itself. So in the cases of intraparenchymal hemorrhage, technologists should know how to take the measurements. On several slices, we can see the blood. So you select the slides with the maximum bleed dimension. Then you can measure the bleed area. So this is in nutshell. The slide summarizes the intracranial hemorrhages according to the location. You can see the intracerebral, subarachnoid, subdural, and epidural hemorrhages. So this slide is on it is on the first slices in the city's brain image. Some technologists may sometimes omit these slides as they assume that first slices are inappropriate for the diagnosis or inappropriate for filming. This image or slice is very important in CT brain imaging. Please check the foramen magnum. You can check the foramen magnum. On the left side, it is open. It is almost free compared to full occupancy of the foramen magnum as seen on the right hand image. On the right side, you have a foramen magnum with the fullness, and on the left side, almost free foramen magnum. The fullness of the foramen magnum is due to the tonsillar herniation, a type of herniation due to the inferior descent of tonsils below the foramen magnum. So never ever omit this image in a CT brain while doing the filming. Similarly, this is one of the top sections of a CT brain. There may be occasions where an technologist may drop this image while filming. Never ever do that mistake. So in this slice, you can see the central sulcus. Central sulcus is very important structure. It differentiates between the frontal lobe from the parietal lobe. In front of the central sulcus is the precentral gyrus, and behind the central sulcus is the postcentral gyrus. So, what is the importance of precentral gyrus and postcentral gyrus? Precentral gyrus houses the motor area, and postcentral gyrus houses the sensory area. So, any impairment or any abnormality to this area causes impairment to motor or sensory impairment to the patient. So if you miss the slide, you're simply missing the diagnosis. So be very apt in keeping these things in mind while you are doing filming. And take your time to get involved with the pediatric brain slices as well. So pediatric brain appearance altogether is different from adult brain. So you take your time to get familiarized to how the pediatric city head is appearing. Let us move on to another important area of the brain, the blood supply to the brain. Brain has got anterior circulation and posterior circulation. So circulation to the brain is very peculiar and it is very important as far as technology is concerned to understand the basic idea of how blood is supplied with how brain is supplied with blood. First, we will discuss the posterior circulation. In the figure, you can very well see the vertebral arteries arising from the subclavian arteries. The two vertebral arteries join to form the basilar artery, and the basilar artery then divides into two posterior cerebral arteries. So, this is the posterior circulation. Two vertebral arteries join on the top above C1 inside the foramen magnum to basilar artery, and the basilar artery then divides into posterior cerebral artery. So in the figure we can see above the posterior cerebral artery there are two arteries, that is the internal carotid. From the internal carotid from branches letting down and it joins with the posterior cerebral artery, that is a posterior communicating artery. Now let's have a look into the anterior circulation. Here you can see the common carotid artery which divides into internal and external carotids. On either side of the neck is the common carotid artery. Then it divides into internal and external carotids. The internal carotids go inside the brain and forms the anterior circulation. The internal carotid artery divides on either side into middle cerebral artery and anterior cerebral artery plus a posterior communicating arteries. This posterior communicating artery connects the anterior circulation to the posterior circulation, and anteriorly the anterior cerebral arteries are connected together by anterior communicating artery. So now the total formation, anterior circulation and posterior circulation, together it is called circle of Willis. Any blockage or narrowing to the supply or supplying arteries, any narrowing or blockage of the supplying arteries to brain may cause stroke or ischemic stroke due to reduced or absence of blood supply. So here you can see the posterior cerebral artery infarct. On the middle there is a middle cerebral artery infarct, and on other side we can see the anterior cerebral artery. An angiogram is the study of blood vessels after injecting a radioactive substance that is called contrast media. Angiogram is usually divided into arteriogram and venogram. Usually people mislead angiogram is only for arteries. Not angiogram is for blood vessel. Angio means it is the record of contrast record of or study of blood vessels. So first one is arteriogram and second is the venogram. So venogram and arteriogram. Any blockage or narrowing that can be well demonstrated in using contrast. The circle of Willis can be here. You can see the circle of Willis very well. In contrast studies are done to distinguish the pathology from pathology and normal tissue. If brain has got any pathological involvement, you can make it evident by applying contrast medium. So here maybe some neoplasm or any tumor may usually tumors have good vascularity. That is why it is getting up in size. So the tumor vascular, highly vascular, uh, very different kind of vascularity tumors are there. Normally they will be vascular than hypovascular than normal tissue. So hence it is the contrast is pooled or accumulated in the abnormal tissues. Is another important thing I am sharing with you, young technologists. The technologists should have the basic idea about the paths of the contrast media once it is administered in the bloodstream. Usually, contrast media is injected into the antecubital vein. Then the contrast medium reaches the right side of the heart through the superior vena cava. The right side has the deoxygenated blood, and the blood is carried to the lungs for oxygenation through the pulmonary artery, the only artery with deoxygenated blood in our body. In the lung, the blood get oxygenated and it is brought back to the left side of the heart by the pulmonary veins. This peculiarity about the pulmonary veins is that only vein with pure blood. Subsequently, heart pumps the blood into the aorta and reaches each and every body part. The contrast study of brain are best done with post-injection delay of 20 to 30 seconds, sometimes 60 seconds and 4 minutes. That depends upon the type of pathology the patient is having. So this is the basic route. So from the antecubital vein, you are injecting the contrast medium. The contrast medium reaches the right side of the heart, then to the lungs for oxygenation, and again came back to the left side of the heart, pumps into the systemic circulation and reaches the arteries. So this is the time taken and the time and the route taken by the contrast medium to reach different organs. So image of the left side is having the pre-contrast, contrast and delayed phases. So A, you can see A, B and C. A is a pre-contrast and B is a contrast. Right after contrast, image right after giving the contrast. Then the delayed film is on C. You can see tuberculous lesions. The other one is abscess and the tumor. The difference, there is a pattern difference. In two cases, we can different pattern of contrast enhancement. Abscess has one pattern of a tumor enhancement. Tumor has another enhancement. So different pathology may have different enhancements. So you just know this type of things are happening in CT prime as a beginner. Once you begin your journey, you will be a master, no doubt in that. So this is the image of cysticercosis infection caused by forked tapeworm. Don't mess it with a delayed contrast. Cysticercosis infection. You're all familiar with this type of injection. It is a motorized or a power injector or a pressure injector for fast contrast administration for angio studies. The working principle behind the pressure injector is Perseola, and you can have two arms. One arm we fill it with contrast, and on the other one we will fill it with chasing bolus that is usually saline. Now we are most of the centers using MDCT or multi-detector multi-row CT to do a CT bright. So MDCT is a wonderful piece of equipment. You can reconstruct the image in any plane. Here some reconstruction techniques are shown. That is MPR is multi-planar reconstruction where you can reconstruct in any plane. You're actually acquiring the CT image in axial plane. Why it is called transaxial scan or CAT scan. Earlier we can today also we are acquiring in the axial plane, but we can reform. On the earlier machines or earlier systems, we don't have the software to reconstruct the image in multiple planes. So here we can have the generosity of creating the image in multiple planes because of the software developments. So that is image can be the accurate axial image can be reformatted into any plane, three plane or any plane, depending upon the requirement of a radiologist or clinician. And another image is very imaging technique, very important imaging technique is the images reconstructed technique is that is maximum intensity projection. So it is nothing but from the pixel values you select the pixels with the maximum intensity. Maximum intensity you also know maximum intensity either bone or contrast has the maximum intensity in the brain. So such pixels you select or such slices you select, the stock together 5 or 7 or 10, then you will get a thick slab or a thin slab. And that is why it is called maximum intensity projection. It is very useful. Maximum intensity projection is very useful in angio studies. Another technique is volume rendering technique is a 3D visualization of bones, anatomical relations, reconstructive surgery, or a surgeon may be helpful with this image. So these are all the additional advantages while you are having an MDCT with ambient softwares like that. So these are MPR, MIP, and VRT. You should be familiar with type of reconstructive algorithms used in decoding methods used in MDCT. And what is CT perfusion? CT perfusion of the head shows which areas of the brain are adequately supplied with blood and provides detailed information about blood flow to the brain. It is useful for measuring blood flow to the brain, important for treating stroke, brain blood vessel disease, and tumors. So CT perfusion is also another decisive imaging modalities helping very much the patients. So whenever you are in a console, in front of the CT console, be confident what you are doing, but don't be overconfident. That is also very much important. This is Godfrey Hounsfield and Alan Cormack, 79 Nobel Prize for Physiology or Medicine with Alan MacLeod Cormack for regarding developing the diagnostic technique of X-ray computed tomography. In October 1, 1971, the world's first brain scan using computed tomography was performed at Kingston Morley Hospital, Wimbledon, London by Sir Godfrey Hounsfield and Dr. Jamie Ambrose. Thank you.